I'm going to call the roll. Thank you, Serena, for recording. And you all remember that it goes by in last name alphabetical order, but I'll call your first name. And so when you hear your name coming, please unmute and get ready to say here. Crystal. Crystal. Sharon. Sharon.
Sorry, I'm here. Sharon Delaranta, I'm medical director at Washington Health Alliance.
Hi, Sharon. Welcome. Tony. Tony.
I know he's not able to make it today.
Great. Thank you. Michelle.
Hi there, I'm here today.
Thank you. Nancy. Nancy. Tracy. David. DC.
Yeah, hi, it's DC. I wasn't sure if that was me or not. Thanks.
Thank you. Sharon. Chandra. Meg.
I'm here.
Hi, Meg.
Hello.
Gregory.
Hi, I'm here.
Thank you. Cheryl. Lan.
Hello, I'm here.
Hi, Lan. Kevin. Eileen. Katina.
I'm here.
Hi, Katina.
Hi.
Mandy. I know you're here. Jonathan.
I'm here. Unfortunately, I won't be able to stay the whole time today, and at some point I'll transfer over to my phone. Just want to avoid confusion for when that happens, but I am here.
Great, thanks. Sarah. Linda.
Here.
Oh, hi, Sarah.
Hello.
I know I'm kind of going fast. It's a long list. I should slow down maybe, but thanks for letting me know you're here, Sarah. Linda.
Hi, good afternoon.
Hi, Linda. Sean. Stacy.
Hi, everyone. Stacy West.
Welcome, Stacy. Jenny.
Hi, this is Jenny.
Hi, Jenny. And Maddie. All right.
Yes, I'm here. Thank you.
Maddie. Thank you. And if I went too fast or you come in a little later, feel free to just send an email to the board box or to Serena, or let us know that you're here and we'll make sure to correct the attendance record. Judy, the roll is done and you can get going.
Excellent. Let's dive in. So we have a slightly different format in terms of these aren't PowerPoint slides, but maybe the next one is, I can't remember. It's been a little while since I looked at this, but we are going to approve the December meeting summary. I forgot about that. And then we'll start with public comment, and then we're going to dive back into where we left off at our last meeting of talking about providers and hopefully talking about facilities, and maybe if we're lucky, getting to the service codes for primary care services, or maybe just start that work. We'll see. So I guess Annalisa.
I will. I'll take them through the minutes. Thank you, Judy. I hope you all had a chance to review the January meeting summary. May I have a motion to approve the January meeting summary, please?
Motion to approve.
Thank you, Jonathan. Is there any discussion? Oh, I guess I need a second. You're right. I forgot all about Robert.
Is DC a second?
Thank you, DC. Is there any discussion or correction to the minutes? All right. We're going to vote to approve. All in favor say aye.
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 Any nay? All right, the meeting summary is approved. Thank you. Whoop, I zipped right by it. There it is.
And it keeps going.
You guys have a lot to talk about. You have long minutes. That's appropriate.
Yes, it is true. So we're a little bit early on the public comment, but maybe I'll pause here and see if there is any. And if not, I'll probably pause again for public comment at 2:15. So anyone from the public like to say anything about our work?
And I'll remind you to unmute and state your name and affiliation before speaking. And also, if you don't want to speak, you may provide your comments in writing at any time.
I think from looking at the attendee list, it is just us committee member chickens here. So maybe let's, oh no, there's a couple, but they are with the Center for Evidence-Based Policy that is gonna start helping us with this work. But otherwise, I think I recognize the other names. So let's continue, and I'll take another pause at 2:15.
Okay.
So where we were, claims-based submissions, we started that last section. And I wanted to remind you at the beginning, this is the definition of primary care we agreed on. I think keeping in mind this definition is going to help us as we keep working towards the where and the what questions that I think we'll get to at the end of this. But team-based, accountable, primary care, primary contact, comprehensive, equitable, evidence-informed, continuous, coordinated are all the super special magic words that we agree excellent primary care is.
And if I could interject one thing, Judy, I'd just like to congratulate you and the committee. You had your primary care definition approved by the board unanimously with no changes, and there was lots of appreciation for your work. So that definition is ready to move forward as part of the board's legislative recommendation, and they and I appreciate that very much. So thank you for that.
Oh, excellent. So last time we met, we had motions to retain the narrow and broad provider list that was proposed at the start of the meeting. We added internal medicine peds to the narrow list, and we removed homeopath from both the narrow and the broad list. And there was a proposal to add midwife and OB to the narrow. It is in the broad, but that was declined. And then there was a suggestion made to add internal medicine psychiatry. And we did some looking. There's actually not a provider code for internal medicine psychiatry. So I think we'll keep that off. And my guess is people pick one that they're doing. But if others have different information, feel free to speak up. But we didn't find that in our looking. So today we are hopefully going to make somewhat quick, but make some decisions about nurse practitioners and PAs, which of course are a very important part of the primary care workforce. We are going to talk about facilities, and then if we have time, we're going to start to talk about that giant Excel spreadsheet we sent you all of primary care services. So NPs and PAs. So as a reminder, these were the folks on the narrow list. So the nurse practitioners have, just like physicians, have a number of different specialties that they can have, or they can have no specialty. And these were the ones that we thought fit into primary care. And then for physician assistants, there's a smaller set, but there is a set. And so we were having the general PA and the PA medical as and not the PA surgical on the list. I can't remember what the next slide is. Oh, yes. So this was the feedback we got. Add all of the categories to narrow, add a variety of these. And I don't know, there may be folks on the call that can talk about the PA, APRN things to add to broad, and there's a couple more different categorizations here. I'm not sure that there are PA categorizations for all of these specialties, but happy to chat about that, and then maybe we'll start there and then we'll go on the rest of the slide. So does anyone want to make a comment about any of this?
Yeah, this is Maddie Wiley. I'm an ARNP. Can you just remind me again, the broad versus narrow?
Yeah, so narrow, we feel pretty sure that most of what those folks are doing fit into the definition of primary care. So as an example for physicians, that's where family medicine, pediatrics, internal medicine is. And then for the broad are people that sometimes might provide primary care and sometimes maybe not. So we're gonna try and get into a little bit of the where and what to help narrow down where these folks are doing primary care. But for example, on the broad list, there's behavioral health, which could be integrated into a primary care practice, or could be standalone that they do referrals, or could be not connected to any primary care at all. So that's sort of where that fits in.
Thank you. And I do think in terms of categories for APRNs, I think we've got them all. There are some school health APRNs, but they're usually fall into either pediatrics or family. So they should be included in that.
Excellent.
Judy, I noticed Emily has a hand up.
Oh, yes.
Hi, I was just going to quickly add, this might be too specific, I'm unsure. In my practice, working with nurse practitioners, it's typically adult and geriatric health is the terminology for their degree. And it's typically adult geriatric in primary care. But I just wanted to raise because I don't see the term geriatric on the list.
Okay, I think that's good. We should add that. Do others have thoughts about that?
This is Linda Van Hoff, and yeah, that's fine. The GEROs are usually included into included into just adult because it's yeah. But I think it's fine if you adult, if you have and then underneath that gerontology as far as add PA APRN gerontology, but yeah, they would be kind of like Maddie says. So this is you have nurse practitioner. There's 4 roles: nurse practitioner, clinical nurse specialist, nurse anesthetist, and midwife, certified midwife. And then you have your population of focus. So I think we've captured all the population of focuses. And then I think with the facilities, we'll capture where the people practice in order to attend to the school based providers, and they can either be they could possibly be just usually family or pediatrics. I guess technically adult, they're just only at college or postgraduate. So, anyway, thank you.
And that does raise one more question for me. This is Maddie Wiley. Why do we have NP psychiatric mental health and NP OBGYN instead of APRN?
I don't know. And yes, I'm not totally sure that physician assistants have all of these types of categorizations.
So it was separated out because the other ones all say PA, APRN.
That is my guess. If you can go back one, who's ever driving the slides. The PA categories that are reported to the Board of Health. Who can go back one slide? I'm not sure. Annalisa, if that's you.
No,
and these all should probably be APR. I'm sorry, I'm mixing it up. Advanced practice registered nurse, if I spell it out, that I get it right.
Yes.
Yes, they should probably all be the 4-letter designation. APR, advanced practice nurse, yes, rather than just NP like this. And so we can make that correction if there's agreement. And then these are the categories that were included in the OFM definition. And for PAs, and we can feel free to have this discussion, but PAs do not have as many specialties assigned to them. There's a general, there's a medical, and there's a surgical. And so that's why it gets a little bit trickier to figure out how physician assistants are practicing, because some of them are doing primary care and some of them are doing other things, and it's harder to sort out since there aren't so many specialties that you train for when you train as a physician assistant. And so these were the categories that we were suggesting to put into the narrow definition. But there's a couple more added in this next, in that set, and then a proposal to move the psychiatric mental health into the broad definition part of for the advanced practice nurses. So you can flip to the next one. It'd be nice to have these side by side, but it's harder to do.
So I would agree, Maddie Wiley here, just to where it says NP only, change those to APRN. That just to be correct and consistent, because you have to be an APRN or you can't practice as an NP.
The NP doesn't really
no
mean anything. Yes.
Right.
So there's a couple on here that I think aren't on the list from before. I think women's health, this set from child and adolescent, child and family, chronically ill, community. I think geropsych isn't on there. And then the APRN, OBGYN isn't on there either. So do we want to add these to the list that it's on the previous page? Then you can flip back.
Hi, this is Linda Van Hoff again. So on the one where it's the, well, we changed APRN, OBGYN, because I think on earlier, we had said we're taking off the OBs off of the narrow list, putting them on the broad list. So I would say for consistency's sake, we probably should use that designation because otherwise they'll be certified as a women's health specialist and caught in the narrow, which probably is appropriate.
Okay, so put the women's health into the narrow definition, but put the OBGYN into the broad definition.
That is what I would think. Maddie, you think so?
Yeah, and Linda, you're suggesting that because the OBGYN category is technically the midwives. The
Well, what I-
APRN midwives, certified nurse midwives.
Yeah, so even though I know they do, because when we were kind of talking on last meeting about, Cheryl Morelli had brought up, and we had talked about, what percentage of focus is on the primary care aspect, but also seeing on the previous slide, not the most recent one, but the another one earlier, saying that the OBs were
Right.
suggested to move them out.
Mm.
We put them on the broad set, so we should probably do that
Right.
here to
Yeah.
have
Be
consistency.
consistent.
Yeah.
Okay, yeah, that makes sense.
So can I have a motion?
So I move that we put the NP OBGYN onto the broad category.
I'll second that. Linda Van Hoff.
Excellent. The ayes
Aye.
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 and any nays? Okay, we are set. Some of these other ones, I guess there's another, there's maybe a couple more categories we should talk about. So APRN, psychiatric mental health. Should we move that to the broad definition or keep it on the narrow? Or remove it altogether?
This is Maddie Wiley. I would suggest that we put all of the psych mental health, including the ones where we differentiate child, chronically ill, community below. If they're psych mental health, they should really be in the broad category because they're not really doing primary care all the time. But there are many family, adult, pediatric who will do mental health in their primary care settings. So, but that should be covered because they would already be in that setting.
Okay, do you want to make a motion?
Linda, you think that's okay? Just get the
Yeah,
other air and okay, good.
Yeah.
Okay, I move that all of the categories on this slide that say psychiatric mental health, the NP one, and then the different mental health differentiation of categories, all be moved to the broad category.
Any
I
seconds?
second that. This is Katina.
Oh, great. And can I have the ayes?
Aye.
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 And any nays? Okay, great. That has also passed and we'll make those adjustments. I think maybe let's flip back. Pediatrics, family health, adult health, and women's health. Are they on here? Pediatrics is on here already. Women's health is on here. Family, there's not an adult health. Okay, you can flip back.
Sorry.
That's okay, sorry, but it's
No.
a little challenging. So should we add the APRN adult health to the narrow list?
This is Linda. We should.
Can I have a motion?
I would, I have a motion to move PAPRN women's adult health to the narrow list.
And is there any discussion about that?
Katina, I'll second.
This is Michelle. I want to make sure, are we moving pediatrics, family also?
Pediatrics and family are already on there.
Already on there. Okay.
Yeah.
Okay.
And
Then,
women's health is already on there. So this is the only one of the 4 that isn't on there.
good. Then I'm in agreement.
Okay. So I guess let's vote. First, the ayes.
Aye.
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 And any nays? Excellent, that has passed. So I think the last piece is one thing that is on there now that I think we should have some discussion about is whether to remove the APRN acute care out of the list or not. And one person suggested to us in the initial feedback that if it's hospital care, it should be removed. Do people have thoughts about whether we should remove APRN acute care altogether or put it on the broad list, keep it on the narrow list?
Hi, this is John Staloff. I believe I may have sent in that piece of feedback. I'd love to hear from our APRN colleagues about to get more of an understanding for what NP acute care entails. Just because if acute care is more like seeing acute visits in the outpatient setting, I'm all for including it. But my feedback was mostly if this is sort of the equivalent of a hospitalist position, then I would recommend striking it from the narrow definition.
This is Maddie Wiley. My understanding when this certification came into being was that these nurse practitioners do round on patients in the hospital and help with hospital care, but they also see, let's say it's a cardiology practice, they have acute care cardiology nurse practitioners who could be certified in either adult health or they could be certified acute. And they are seeing those patients in the offices in a primary care setting as well. So I would suggest moving them to the broad list, I believe, is the way that's probably best handled.
Yeah, that's my understanding too, Maddie.
This is Michelle. The only other thing to think about is the CPT codes. If we don't include the inpatient visits, then those are going to get excluded anyway. But there is going to be an issue with trying to figure out if they're working in a specialist office versus primary care. So probably be better to move it to broad.
Okay, can I have a motion?
This is Michelle. So I move to suggest that the which one is it that we're looking at? The
APRN acute care.
APRN NP acute care be moved to the broad list.
And I'll second that.
I second.
Well, we'll both second it. There you go.
Perfect. Okay. Let's vote. I'll take the ayes first.
Aye.
Aye.
And any nays? Okay, that motion passes, and I think we are done with APRNs and PAs unless people have anything else they'd like to add. I think this last point is that only include them if the provider's at a primary care facility, and we're getting to the where next, so we will talk about that there. So oh, and I guess, well, I'll pause to see if there's anything else. And I'll also pause because I forgot to pause at 2:15 if there's anyone that would like to make public comment that is still around. Now is a great time to speak up for that too. Emily?
Thanks, Judy. Oh, sorry, for the record, Emily Robson, Foundation for Healthcare Quality. I just had a clarification when you were voting earlier on removing the different psychiatric nurse practitioners with the different specialties from the primary care, the list. I'm not as familiar with the idea of integrating behavioral health care and how we're trying to do more of that with primary care settings. So I didn't know if that idea would make it where you would prefer having those lists of practitioners on the narrow versus broad list.
So we are all for integration here, and having them on the broad list still includes them as primary care. And the services, so but it's not, because some of those services are not, maybe to go back to our definition, the comprehensive, continuous, they're a slightly narrower place. They're still included in the primary care definition, but more in the broad definition rather than the narrow one.
Thank you. I just appreciate that clarification.
Yes. Okay. Then can we have a motion to approve the finalized ARNP and PAs list? And again, we'll change the NP part of this everywhere for our future meetings.
Maddie Wiley, I so move.
Lynn Wynn, I second.
Great. So we'll take a vote. All the ayes?
Aye.
Aye.
And any nays? Okay, we have a list. On our provider list, the WHO is done. So, so check, very exciting. So the next piece that we are moving on to is the where, or facilities. So as a reminder, these are a variety of facility codes that exist that I think we have put as possibilities. We got this list from Josh and Lau and his group at the University of Washington, who's done some primary care work for us. And they found that the location group or place of service code, which is what these are, was a reasonably valid code in their place. With E&M services, it gets a little bit trickier because there are some broader ones that it might fall under, but I think we'd like to have a discussion about the where. And then as an aside, we may want to have a discussion after we're done with this. If there is any, I guess, ranking of which is most important in defining primary care. Is it the who, is it the where, is it the what? So they may not be of equal value, and that might be something we want to chat about. So this is our list of proposed facilities. So primary care, including ones that are on site at hospitals, since a hospital campus can have primary care on it. Multi-specialty clinics or centers, again, these may not all be primary care, but picking out the provider type and the services will help us narrow that. Rural health clinics, federally qualified health clinics, ambulatory health clinics, community health centers, critical access hospitals, school-based health centers, Indian health service facilities, and long-term care facilities. And next, I think we had the feedback. So one was to make sure that primary care clinics within hospital outpatient departments that have primary care providers are included. One person wanted, or maybe more than one, I don't remember all of these, wanted to add urgent care clinics, virtual care, which we can chat about and where that fits. And then these two codes for group multi-specialty or group single specialty. Other feedback is to remove critical access hospitals if they don't provide primary care. And a question about, will only facilities using method 2 for professional billing be included? So does anyone want to start the discussion about our facility list?
Judy, is that list of facilities based on the claims place of service code? Like, how is that?
Yeah.
Because I'm just okay. So I'm just going through the list right now just to see what's captured. And I'm going to start at the bottom because that was, I think that was my comment. The method 2 billing that applies to critical access hospitals. So I just wanted to. I wasn't sure when we added critical access hospitals. Obviously, we don't want to provide all, include all services that are in there, but
right.
Those that are under the method 2 billing, they are billing for professional services that could be primary care. So that's the only thing that I wanted to make sure that we were clarifying.
Yeah,
sorry, I'm thinking through my head right now.
No, that is actually a good question. And it's probably something we should take back. Annalisa, if you want to note for us to do a little digging on this about how we're, or if we're able to sort out the method 2 part of critical access hospitals.
I'd be happy to do that.
Unless anyone else on the call knows, but I don't 100% know, so I shouldn't talk, although I think I know what happens, but yes.
Judy, this is Katina. I'm in my car driving, so if there's a lot of noise, I apologize. I have two questions / comments. For the multi-specialty clinic, and the example that we used a minute ago with the nurse practitioner, the APRN who was doing adult medicine in a cardiology clinic, how does that person get excluded if they're doing cardiology in a multi-specialty clinic rather than primary care within the multi-specialty clinic? That was kind of one comment question. And then I would like to hear more about the inclusion of urgent care as primary care. And is there a role to be a narrow and a broad with the location as well? I think we know that patients often use urgent care clinics as their primary care clinic. However, does that really meet our definition of comprehensive, all the buzzwords that are included in our definition?
Yes. Maybe we'll start with the second part of your question, because I do think that is a good place we should discuss. Does urgent care belong in our primary care definition or not?
This is Maddie Wiley. I do know, I work and live in the Kent area, and in Renton and Kent, there are some urgent care clinics that also advertise that they do primary care. So patients can make appointments and see a primary care provider, as well as either walk in or make appointments for urgent care stuff. So I don't know what they actually set themselves up with. Are they actually noted somehow or other with insurance or definitions that they're both urgent care and primary care? I don't know.
I have a
I
follow-up
guess
question.
my question is, are they meeting the definition? Because my experience in looking at this is they won't meet the definition generally. They may advertise, but they don't meet the definition.
This is Sharon. Sharon Alaranta from Washington Health Alliance, and we are seeing, and this will come out in the next week or so in our community checkup, the really obvious downside of not having an attribution of a patient to a primary care provider. And my question about, if you see an ARNP or a physician, a DO, an MD, whoever in an urgent care center, are you forming that type of effective longitudinal relationship that will help, ensure that you get what you need over time and nothing more, blah, blah, blah. Yes, maybe they can look in your throat and do a strep test and say, well, that would be a thing that would happen in a primary care clinic, but it's kind of not the spirit of the game, is it?
Yeah, this is Lan. I would add to that definition with, these providers, who provide primary care service and urgent care. Is it continuous? So are they carrying a panel of members and patients that can say, this is my PCP who I go to from beginning to end? Or is it incomprehensive? So are they able to provide an array of services besides the acute care services in who claims their primary care? So that would be, do you know, Madeline?
No, I actually do not. I just know that's the way I've seen their advertisements, and I've actually driven past one of their clinics in a parking lot, and it clearly said on there that they did both urgent care and primary care. What their primary care so-called did, and were those patients really being attributed to them as primary care? I don't know the answer to that.
This is Michelle. One other thing I wanted to add is, with the primary care transformation goal in Washington, part of that is to expand access in the PCP office. So offering hours outside of normal, 9 to 5 hours, which is supposed to try and then limit the need for urgent care centers. So in my mind, I feel like they're more episodic in nature than primary care.
They're completely episodic.
I would completely agree. I think. Go ahead.
No, please continue.
I was going to say I completely agree, and I can see how advertising, you can be a primary care office who also offers urgent care, but being an urgent care office that does primary care on the side, it feels a little strange to me as a primary care physician. And I wonder, is it marketing and optics that really they're trying to bring people into their practice? But I think the spirit of urgent care is not the same spirit as primary care. And if we include urgent care, then we include the emergency department, who also has many patients that chunks of their primary care.
Maddie Wiley here. I'm right. I just wanted to bring it up for discussion. I've never had a patient transfer into me who had been using a PCP in an urgent care place, but I don't know, because like I say, they advertise some of them that way. But I totally agree that really they need a PCP, not an urgent care place, to be getting their primary care.
I think a lot of these good discussion would also apply to virtual care too, as being episodic, because I have seen some virtual care groups being advertised as primary care as well. So some of the points can also apply to virtual care.
I think you're right. This is Greg again, and we've looked at this pretty extensively in any of the virtual offerings that we provide. And while I think some of the virtual offerings fill a very important niche when you can't get help anywhere else at 2 in the morning, even as I think as comprehensive as some of them try, I do not believe it is full primary care that would meet definition. And I think one of the key things is you, at least to my knowledge, and I could double check on the virtual component, if it's a virtual only service, you have no control of who you see. You would never, unless it was pure luck, see the same clinician twice.
This is Sharon again, and I totally agree with what Greg is saying. Like, for example, like I'm in the Kaiser system and I have had all of one virtual visit, but it was with a person on my primary care team, and I made the appointment through my primary care provider's office.
Yeah.
So it was,
yeah.
I believe in
I've done-
ARNP, but yeah.
Yeah, absolutely. The question I was going to ask, and I apologize because I just don't fully understand enough of this detail sometimes. I do think there are, well, and maybe DC has an opinion on this. So like UW Medicine has urgent care facilities. They're usually or the one I use is connected to the same building where my primary care physician works out of. So there's that like full integration. And sometimes I think somebody from the primary care clinic may, also work out of the urgent care clinic. To me, that I'm not sure if I would fully define that as primary care, but it's also, I would view it as a good thing. Because if you end up in urgent care, they're going to encourage you into that relationship. And if that doesn't even fit into this discussion, I apologize. I just wanted to kind of raise that issue because I know it exists, and I think there are certain organizations that do that really well.
Hi, this is John Staloff. I work in the UW system, and I do agree. I think it's great that urgent care is well integrated with primary care, but also, I think that's largely a reflection of being a part of generally an integrated delivery system within UW. And the similar things could be said about really good transitions of care between the emergency room and primary care, which also exists. And so I still definitely agree that urgent care should not be considered primary care. And also to piggyback on the virtual care discussion, I definitely think there should be a distinction between organizations who are telemedicine only, like Teladoc, as opposed to organizations that have also provide telemedicine services. And I would exclude telemedicine only from primary care by virtue of it being impossible for them to be delivering comprehensive services. Because if they do, then the point of a physical exam ceases to exist. But I would include brick and mortar facilities that offer telemedicine services.
Carrie?
Thanks, Judy. I just have a question about the assumptions around the patients. Are we assuming that everybody has access to primary care that operates from 8 to 3 or 8 to 5? Even with extended hours, are we assuming that primary care will extend to 24-hour services? And so does that leave out a bunch of patients who will never be able to access primary care during that time?
I think our goal ultimately, again, thinking about that big definition, is that people do get access to primary care if they want it, and that primary care is a good thing for people to have. I think that may, and certainly now, that doesn't always happen, but part of us being directed to measure primary care spend is to figure out what that looks like now and how do we increase that spend to 12%, which presumably happens by clinics offering later hours or offering virtual care or other things like that. There's for sure a workforce component, that there needs to be enough primary care folks, doctors, nurses, PAs, that can do that. But we are trying to measure the spend on primary care so that then we can talk about ways that we should increase that spend or ways that it should look different.
Yeah, I'm just wondering if you're leaving out a chunk of people who get primary care. It should be measured, but maybe it won't be captured. And I don't know that urgent care is the way to capture it. I'm just asking a question from a patient perspective. What would those patients be measured in this formula or with this definition?
I guess I'm a little bit confused. Where would they be going? Or
You know, a lot of people will go to urgent care because they work, they have no access to primary care in reality in their lives. They're not going to be counted in this under this definition. And it may change for them over time, so it may even out. I'm just wondering about that consideration of a patient perspective.
I have, this is Katina again. I have a comment about that. I think that that is a valuable point, is that patients are often getting their primary care via this way. And I think fundamentally, one of the things that we want to do in our state is have more true primary care that meets the definition that we agreed upon. So the fact that maybe we don't count these people getting their primary care and really non-primary care ways from the beginning, and say we only have 3.6% of our spend, and we improve that so the folks that were getting their primary care in this non-primary care fashion will be included because we have transformed primary care in our state in a way that people are able to connect with their primary care physician or PA or advanced practice registered nurse practitioner. So I think there's an argument to not capture these folks to help us get better, and then we will be capturing them within the confines and the definition of really excellent primary care.
That's a helpful perspective, Katina. I'm just I'm wondering how realistic it is, or I'm wondering too about like a baseline, if it's going to lead us in a different direction of measurement.
This is Michelle. I wanted to jump in. I'm kind of agree with Katina, because I feel like one of the ways we could measure this is, when we start collecting the data, you would measure what percentage of care is being done in urgent care settings versus, what we're seeing in primary care. And we're going to hope to see that primary care goes up and that urgent care goes down. So it's still something that we can trend, that we can monitor, but it is a way to show we're trying to improve, we're improving access to primary care because the amount of volume going to urgent cares is being reduced. That's kind of like the trend line we'd want to look at. I think if we include urgent care clinics, that's going to probably overstate, the true primary care spend. And we may say, oh, we're already at 12% and not do anything, when really that's not the case. We need to yeah, we all know we do need to invest more in primary care. So
This is Linda. I was just thinking though, too, when we talk about the patient and that idea about where they're choosing to seek care, where we've got that third threshold, which is the services provided, right? So there's different ways to grab the data from these different particular places to really look at what services are provided, which also might allow us to understand the primary care spend or the primary care services that are seen to be given out in what should be an episodic urgent care way instead, opposed to, but some people do continue. I mean, when you see a patient coming into primary care, sometimes they have seen the same 3 providers at the urgent care clinic repetitively for a multitude of things, which would be a composition of primary care in quite the same way. And then they finally maybe land in my office. But we have that other, we have that other level of collection, which is going to be the bigger thing to get through too, but is the services provided.
I'm on mute. Mandy.
Yeah, I was just going to say that, you know, the definition includes procedures along with providers. And so, you know, I've worked with the claims data, and I don't believe we can tell if a clinic is an urgent care clinic based off of the claim, because other services, I don't believe we can tell that from the claims data. So what we would have to go by is the providers, the type of providers and the type of services that were included on that claim.
There is an urgent care flag, so I think not everyone uses it, but if it's there, I think, I don't know, we'll see if I am summarizing this conversation. It sounds like if it's there, we would not want that to be added into primary care. If it's not there and it's not clear, like maybe the UW urgent care clinic that's part of the system, my guess is that that is probably coded as a multi-specialty or something like that. Then I think that we would put into the primary care spend bucket. But I think if it's labeled as urgent care, it sounds like we're coming to the spot that we don't want that on the facility list. And Sharon?
Oh, I was just going to say, I just quick Googled it, and there is a place of service code for urgent care that's different from the ED one. That ED is 23 and urgent care is 20. And whether people actually use place of service codes, you know, well or often enough, it's starting to sound like, I don't know, I don't want to summarize, but kind of like we probably should kind of track how much primary care is being, you know, offered in these non-continuous settings, so that we can try and guide people into having a continuous source of care and not fail to collect data on it. But I don't know.
Sarah?
This is Sarah. I work for Kaiser. I do a lot with our claims data as well. We do often see that the urgent care place of service is used, and usually we have more of an inverse problem where we have a primary care physician providing urgent care, but in their clinic. So that's usually sometimes the issue that we have. It's sort of an inverse to what's being discussed.
Yeah. So since urgent care is not on our facility list right now, I don't think we need a motion to take it off or do anything. Does anyone, so we'll just keep this off of our definition. It may be useful, as Sharon said, to measure it in other places, but we are hyper-focused on primary care. And so I think from the conversation we just had, not including it is is probably the direction you want to go. Is there anyone that disagrees with that? Okay, check. So virtual care, I think we started to have a bit of a conversation of if it's all virtual care, it's probably out. I am not sure how the teledoc or the sort of those different services bill. There is a modifier for telehealth, and so I think and we would want to encourage primary care to,
That is correct,
have people get seen by their PCP virtually and in person. So I think we probably don't want to exclude virtual care or telehealth altogether. But yes, I do, I think we'll do those different things. And I don't know if anyone knows about how the fully virtual care kinds of providers that I would sort of lump into the urgent care category, how they bill for place of service.
I could find out
Oh, okay.
if that would help.
That would be helpful.
I mean, many of them don't bill straight claims.
Oh, that's true.
But
they bill the plan or the employer in sort of a different way.
yes, but if it would help, I could, I'll just see what I have easy access to, because we've looked at a lot of these services and probably have a bit of a summary. And if they do bill claims to the health plan, I will ask for any background specifically on how that's typically done.
Great, that would be helpful, Greg.
Yeah, sure, happy to do that.
This is Sarah Stokes with Kaiser. I just pulled a report of our telehealth visits. We have a really good claims reporting system. There is a telehealth place of service. It's code 02. But we also see that it gets billed as office, pretty typical as well. And there's also a place of service code 10, which is telehealth provided in patient's home. So those are the top 3 places of service that are used with telehealth based claims.
Great, that is helpful. And I think, yeah, we wouldn't necessarily want to exclude those if it's the person's primary care person or primary care group that is providing that care. So I think primary care clinics that are on a hospital campus, I think they are included in what we have on the previous page of this. So I'm not going to discuss that. I think the next piece of things we should discuss are these 2 facility codes here for group multi-specialty and group single specialty. Does anyone want to talk about that?
So those are taxonomy codes that you're saying would be billed under a group specialist with that taxonomy? Is that what that is?
Yeah, I think those are taxonomy codes. And so should they be allowed as place of service codes for primary care or not? And where I've seen them mostly used is in true specialty kinds of areas, not in primary care. But I don't know how how true that is and what the group's thoughts are about including that or leaving that off.
Judy, this is Katina again on the the multi-specialty group. If there was a internal medicine clinic and a cardiology clinic and an endocrinology clinic, and we were able to, track the folks that were working in the internal medicine clinic and not the other two clinics, including our advanced practice nurses and our PAs, that would be wonderful. But again, the concern is over counting primary care, or a family physician that's doing sports medicine in an orthopedic office, and there's also a family medicine clinic within the same multi-specialty office. Do you have info on how often that might be the case to overcount?
I think that could happen. I think one of the hard bits of this, and the group that struggled with this on the OFM effort struggled with this too, is that the bulk of codes that are billed in a specialty office that might be with a primary care office is E&M codes that you can't really tell whether it's a specialist or not. And so you can't kind of pull those things out. And similarly, particularly for physician assistants, less so for advanced practice nurses, but you can't always tell what kinds of things they're doing. What the OFM report did was decide that 60% of PA services were primary care, and that was a judgment call because we didn't have good numbers and we didn't have good things that we could sort of put our finger on, but we knew it wasn't because PAs work with specialists a lot too. There wasn't a way to sort of pull that out. And so, if we could do what you just said, Katina, I think that would get us the gold star. And I think we can't do that with the billing data that we have. And I'm happy to take other thoughts about that or, comments. I don't know, Mandy, if you want to talk about how we got to that PA percentage.
Oh, that was On Point, I think, was the one who had developed the methods for that. But yeah, they essentially took a percentage of PA. And I think that was based off of the feedback that we had received from the work group that we had convened at the time. And so it wasn't just a number we pulled. I mean, it was us working with a lot of the work group members to come up with a percentage that we all agreed on.
So does that make people more enthusiastic about including these two or less enthusiastic about adding these two?
This is Michelle. My concern more is overcounting primary care by including these. It's going to be too hard to parse out the primary care piece.
This is Maddie Wiley, and I would agree with that.
Okay, so I think I'm hearing consensus and silence that we leave these out. And since they're not on the list, then I don't think we need to add them or make a motion. The last piece about this, and I think this is something Annalise said that we will have to take back and look a little more into the critical access hospitals. And so we will we will bring that back to you at the next meeting and talk about critical access hospitals.
Great.
So we have our list. So I think the next slide, does anyone want to make a motion to approve our list? And if there's something we need to come back to at the next meeting, we can always make another motion to finalize the list.
Is Crystal so moved?
I move to approve.
Okay. Can I take that as a first and a second, Annalisa, since there were two people? Then
Yeah.
let's vote. So let's hear the ayes.
Aye.
And any nays? Okay, check. So we have a who, we have a where. Now we get into the hard part, and we do have, I'm excited to see, about 45 minutes to start to dive into this. So hopefully we'll make some good progress. The what. So we sent out to all of you the Primary Care Collaborative's Excel sheet that compares states. So I hope you all had a chance to look at that and see what was included and what wasn't. Some people ask questions. We were the only state that divided into narrow and broad categories. So we can decide whether we want to continue on that path or whether we want to do what other states did. I will also say that in that comparison, we had more codes covered than most other states. Colorado was getting close to us, but in my look at it and relative to the last conversation that we just had, it seems like states were concerned with the over counting of primary care things. And so a lot of states stuck with a relatively narrow list of codes. And so the world is our oyster and we can decide what we want to do with that. But I wanted to give you that sort of background. So next slide. Oh, nope. No, next slide. This is where we put the Excel sheet, right?
Have to do the fancy thing. Give me 1 second.
Okay. We played a little about whether we could put this on a slide or not, and I decided it was just easier to do the Excel sheet. And so I think that we'll go down and you can either follow along with us, or you can look. I think it looks like it all fits, which is quite exciting. So yes, so to orient you to this, the green is keep in. I think the yellow is to remove.
Well, the yellow, I know.
There's the yellow to talk about.
The yellow were suggestions from the committee to include. So we want to stop at the yellow because some committee members should want to talk about that. Green was suggestions to keep. That's from our clinical staff at HCA, additions that were made by clinical staff. And we'll get to a pea green a little later, and that is one that committee members wanted to take out. So I think yellow is really what we want to focus on.
Yellow is talk about whether we put in or not, and white is to keep out, I think. I think the list that we sent you was green, put in, and white, keep out. Yes, I haven't looked at this in a while, so thank you for doing that. And so I think we'll just start down this list and make some decisions to move in or move out. So, so skin tags. What do people think about skin tags?
Don't think about that.
This is Lan. That's a procedure that I did regularly in my primary care setting.
And in our primary care clinic, Maddie Wiley here, we do a lot of skin tags. So we're looking for things that should be included in primary care. And you don't want these people going off to, it's cheaper to do it in primary care than say go to dermatology or specialty care. So I would leave it in.
Okay, we have 2 people on the leave it in side.
Yeah, this is Katina. I agree to keep in all the skin tags, no matter how many they have.
Okay, can I have a motion to include the 2 skin tag codes?
Maddie Wiley, I so move.
And I second.
Great. Let's have an aye.
Aye.
And any nays? Okay, let's make those puppies green, Annalisa.
Oh, God. If I can't do it, we're just gonna know that it's all on video and I'll fix it later.
Okay, that sounds
But in the
good.
meantime, you can head down to the darker green ones if you want to pause there while I just think about color changes.
Oh, yes, it might not work. That's okay. So the green ones are in. I think we don't need to talk about
Okay,
that.
great.
Yeah, so then the next one, these are all a little different. And so I think we'll just take them one at a time. So the first one is closed treatment of a radial head subluxation in a child.
Judy,
Yes.
this is Linda Van Hoff. Just going back to the whites, because I know the whites are not to be supposedly included, but the evacuation of a subungual hematoma, I know, hey, it doesn't happen every single week in my practice, but that definitely is something that I do in primary care regularly as it comes through. So I know it's also something maybe people don't see urgent care for, but I mean, it's a procedure. When I look at that block of below the skin tags, I thought, as far as the frequency, that definitely that comes through. So I was thinking maybe we should include it.
So I want to note that we are not trying to get every single code that primary care does, because all of these things are things that primary care does. But we are trying to focus on sort of the bread and butter of primary care. And I will point you back to our definition again of sort of what those services are. And then I'll also point out, because I think it's helpful, early on in the committee, we talked about, isn't there a national definition for this? And there is not a national definition for this. And so, as you can see, every state does it differently. But this is one that we are the only ones that include. And besides the states that you see across, Milbank is a sort of think tank that does a lot of primary care policy work with states and other stakeholders. So they have a version of primary care spend. And then I think the other one is the NESC, the National Academy, or is that something else? I can't remember what that stands for, Annalisa. I think it's a multi-state, maybe it's the New England State Consortium. That might make sense.
I would vote for that. No, I'm sorry, I don't know, Judy.
Yes, no, that's okay. Okay, so now let's chat about, do we want to include the evacuation of that hematoma or not?
Well, this is Maddie Wiley. I had the same thought when I read it. It's like, we do that in my office. It's actually a very simple procedure. You don't need a lot of equipment to do it. Again, it just goes back to, how many procedures are we going to put in as part of primary care? But if we're trying to keep people out of urgent cares, then we have to somehow or other identify how much of this is being done.
I agree, and I think there's a variation depending on, the provider's scope and comfort level too, especially if they don't do a lot of it, then they end up, in the beginning, maybe doing a lot, but then if the volume's not there, then become less comfortable, so.
I mean, I think if we can justify, I mean, looking across we would be the only location of all these reports and all the states and locations, we would be the only one that would actually have included that one. So as long as as long as we have documentation about why, then, I mean, I'm fine for including it.
I agree with including it. This is Katina.
Okay, does somebody want to make a motion?
Sure, this is Linda. I'll make a motion that we include evacuation of subungual hematoma in the list of procedures.
I second, it's Lan.
Okay, and can we have some ayes?
Aye.
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 Any nays? Okay, well, we will turn that one green. And also, Annalisa, the second skin tag one should be included too. Yes, perfect. So back to closed treatment of the radial head subluxation. Does anyone want to make a case for including that? As it is, I think it is left off. Okay, how about the next one? Removal of the foreign body from the nose. Oh, those little kiddos and things they stick up their nose.
I think that
Again,
should be included.
Go ahead,
From the
Linda.
ears. I was gonna say from the nose, from the ears.
Yes.
Foreign bodies and any orifice we take out.
That is true.
I agree.
Do people think it should be on the set?
This is Michelle. I'm not clinical, but the fact that nobody else has included it makes me think we should probably not include it either.
So Maddie Wiley, just a point of clarification, because we're trying to include things that are going to go into this primary care bucket. But if somebody does something in the office in primary care, it's not like they're not going to get paid for it. It just won't get counted as part of that primary care bucket.
So one way to look at this might be you will still get paid for whatever of these things you do in primary care as a primary care provider. But one thing I know that that Colorado did with their list is that they had sort of a bundled payment that looked at all of these things. And so we are not proposing that for this list at all. This is to measure primary care spend. But I do think that looking at where the other states have a lot of no's, I think how other states have looked at it is things that happen a lot in primary care, the things that are sort of the bread and butter, the things that that sort of happen all the time. And so I think that's sort of the lens, is that we shouldn't be trying to put everything that happens in a primary care office, because again, remember, we will have some providers that might be working in urgent care that might be doing other things that we wouldn't necessarily, that we might count as this is in primary care, because we won't be able to tell from their specialty and location whether it is or not. And so that's sort of the piece we're I think trying to balance.
So Judy, this is Katina again. That when we're looking at the three buckets, to be in primary care, do they have to be in all of the three buckets, the location, the provider type, and the service? So say say you have the radial head one that we just talked about. So if that was a pediatrician doing it in a pediatric office, doing the procedure, because we don't include that procedure, the cost billed out for doing that procedure wouldn't count because the procedure wasn't on our list, but the office bill that was billed for evaluating that would count versus like a rural ER that had a family doc doing the procedure, but they were in the ER because it's not in our location. I guess I just got confused by the dialogue around only the bread and butter, and other states aren't including it because it's not bread and butter. That's where I'm struggling in my brain.
Yeah, so we're trying to get the bulk of spending in primary care. And so I think other states haven't included this, both because one, it doesn't happen every day. And I think two, it's too hard to tell, and coding isn't always accurate, whether it really happens in a primary care office or not. So as an example, Katina, this might happen in by a family practice doc in a sports medicine clinic that's on a hospital campus. And so we can't tell whether it's true primary care or not. And so then it would get counted as primary care if we had it on our list. And again, the goal of this list is to increase primary care spending and focus on that. And I think that other states have taken the tact that if you include sort of all of these things, that's not getting to the goal of getting it like what's the heart of primary care, and how do we make sure that people are reimbursed for those kinds of things. And so I think that that's some of why it hasn't been included on other lists. And other people that are on the call, feel free to talk about that or what they've, I know there's some people, although I think Tony was maybe involved with Oregon's list some, but he's not here today. So I don't know, maybe let's step back from the list a minute and have this larger philosophical conversation.
So Judy, to reiterate, we don't have to meet all three buckets to be included in primary care. If they hit one of the buckets, then that's included. Is that what I'm understanding?
No, we are using the sort of who, what, and where to get at that intersection point of the three. And it won't be perfect. So we don't have, you know, people can do different things under their license. Family medicine is a great example of that, that you could do different things without getting another kind of specialty degree, internal medicine and pediatrics as well, or you could get a specialist degree. And particularly there are fewer categorizations for advanced practice nurses and PAs, and so they're more general. And so getting at that intersection point is where we need to be. And so, yes.
Thank you so much.
This is Lan. I would offer that you were asking if this was the bread and butter, and some of these procedures, I would say, you know, having providers that I manage, you know, out of 15, one might do it, but it's not their bread and butter, right? So I think it really depends. And a part of it too is not because that the provider doesn't want to do more of a certain procedure, But, you know, as a medical director, we look at the cost and the resources, right? If they want to do a procedure that they're 1 out of 15 that will do a colposcopy, for example, we have to pay for the equipment, right? We have to get the referrals, and there's process and operational things. And so sometimes we discourage, you know, certain procedures being done in primary care setting, not to the fault of the provider, because they do want to do it more, but we, as the, you know, leaders, don't give them the resources. So just want to throw that out there too.
Yeah, and I will say that not putting it in our primary care spend doesn't mean that we don't want this to happen in primary care. You know, not having it on this list is not going to make payers say, oh, I don't want to pay for that in primary care. I think a lot of these things we would want primary care to do preferentially as to any other specialist. But in measuring the spend and how much money gets paid to primary care for things, I think that's where we're sort of trying to focus a bit in figuring out what is primary care and what isn't. So that part, I think, gets a little trickier. And I think by far, I'll say from my experience, and I'm sure a lot of you will say that too, the most common thing billed, like over and above in primary care, is E&M codes. And occasionally some of these other things will be done, but the bulk of what people do is E&M codes. And so some of these, I don't know, maybe if it's helpful to sort of scroll down and get a sense of where all the states are in unison, that might be a helpful piece for this conversation. Annalisa, if you can scroll down.
Yes.
Slowly. So there's a chunk of sort of OB things in or out. You know, all of these lab tests, I think, could be done by primary care, but aren't. But then here's a good example of immunizations. Like everyone except for Massachusetts, and I don't know why, but puts in immunizations as something that's really high priority, and like this is primary care. EKGs aren't in there except for our state, because although primary care can do them, they're often done other places, and it's hard to tell. It might overcount where primary care gets to. I think keep going down. So here's the E&M office visits, you know, and telephone services are in here. That's sort of across the board where other states put in this. And then I think there's some variation sort of as we go down. These are services in nursing facilities and rest homes. It used to be, and it is probably still in some areas of the state, that primary care goes into nursing homes or domiciliaries or rest homes to see a patient, but it's in big cities for sure. The nursing home hires its own doc or advanced practice nurse to provide care for their patients. So it really sort of depends. And then keep scrolling. So home visits are pretty broadly covered, and team conferences, which sort of starts to get at care coordination. This next chunk of ones that are green all the way are preventative visits and preventative counseling. So that sort of gives you a sense of where other states have put their bulk of things in. So collaborative care codes and the transitional health codes, I think, are on here. There's some more vaccines. I don't know, I might stop there, but does that help people sort of get a sense?
Yes, that's really helpful.
Of kind of what other states have done. And again, there's not really a right or wrong answer. But I think the bulk of what people have gone after is kind of those big pieces. Yeah. I'm trying to see if there's anything I can sort of find about other states quickly of like the why. Again, anyone that knows anything about what other states have done has done this, but I think, yeah, that's sort of the place for doing this. So should we go back up and start to work on this some more? And yeah, again, all of these things are things primary care does for sure. I think the question is how much we want to emphasize this in looking at the total spend. And maybe another frame would be if we want to increase primary care spend, what things do we want to target that increase for? So, you know, one, and again, I don't think anyone's doing this, the ledge isn't doing this, but you could take this list to the legislature and say, increase funding on all of these things that we marked as primary care. And if that happened, that would be, you know, for everyone, not, it's hard to sort of do this at the point of billing, of figuring out, does this count as something that should be increased or not? And so, again, we're not trying to do that. We're just trying to figure out how much money is spent on primary care, and then how do we increase that? And I don't know, just also throwing it out an idea. This might also be a place that you would want to think about using the data to help us decide. So if the data says, I don't know, some of these things cost more than others. So, you know, if it's less than $10,000 overall in our data set, or less than $50,000, or I don't know, pick a threshold. Maybe we don't want to include that, and we could use that as a final check before we finalize the list. Once we get to the point of being able to measure this, we could do some kind of sensitivity analysis sort of thing. There's a lot of ways we could go at this. So I'm going to stop talking now and listen to what you guys have to say.
Maddie Wiley. So things like your venipuncture, it could be done anywhere. So
Right.
that would make it harder to differentiate. Hey, did they do this in a primary care office, or where did they do it? So that makes sense. I understand that. In circumcisions, you know, there's some pediatricians who do them, some family practice, but not that many. And the majority would be done probably in specialty.
Yeah.
Right, urology or wherever. So so it might be harder to differentiate. So I guess I understand what you're saying, like, hey, leave those out. But I did, two things struck me when I looked at this the other day. Well, more than two, I'm sure, but under 58300, just below that, we're going to insert an IUD, but we're not going to take it out in primary care. I just thought that was kind of odd.
Right, and that might be one we want to add in, which
right, because up above we are removing and inserting the implantable rods, you know, the rods, yeah. And my other thing, I think I sent you guys an email, was that under the labs lead levels, we are, according to the state of Washington, anybody who's doing well child care, we are supposed to be checking lead levels twice between the ages of 1 and 3, which you're either venipuncturing and sending it out on every poor little kid, or you're doing an in-office procedure, which those are expensive for primary care to have in their offices. So it's
Or
just
you're
something
not
that struck
doing
me.
it.
Or yes, and there are many
There's a lot of
offices, because yes, I get transferred patients in, and their child's like 18 months or 2 years old, and you're like, have they had their lead checked? And I'm like, huh, what? And I realize that. So working in an ARNP office, we always like to make sure we've crossed our T's and dotted our I's. So we do it, but it just struck me that, well, we should kind of be including that in primary care if it's actually technically it's the feds who are giving the money to the state of Washington for Medicaid are kind of like, you need to be doing this. So that's where that comes from, as I understand it, background wise. So
yes, no, it comes from the feds, and I don't know. I haven't looked at the list lately to see who's still on or not. I know a lot of pediatricians have feelings about this because the tests aren't super accurate and they're painful, and yeah, CMS has now made a way that states can sort of test out of doing the lead by showing that they have a low enough lead level if they tested every kid, but it's really hard to do. So yeah, and then we have places like Flint that has it in their pipes, and then you're like, oh my gosh, maybe we should be testing. So yes, that is a whole set aside discussion about the politics of lead testing. Are there others? Are there others that want to talk about the general approach or things? Again, I don't know that there's a right or wrong way to do this. We don't have to follow other states, and we might want to on particularly on some things. So yeah.
Judy, this is Katina again. The comments around the circumcision in rural areas, that is definitely done by primary care most often, less often by our urology colleagues. So I would kind of vote to keep that in. And then I really love the prenatal care portion that's on here as primary care. I think us in the Pacific Northwest, we do a lot more primary care from family physicians than in many parts of the country. So I would love to see that, particularly with the residency program in our state. We are definitely considerably different than many areas of the country as far as prenatal care done by primary care. So that's a couple of comments around that.
Yes, I think if we're ready to dive into comments, we should go at them one at a time again. So maybe we are.
That would be helpful, because I'll need to capture input and Judy, you seem to be doing a motion for each one you want. So
I think so, because I don't know, we could, some of them are groupable, like the 2 skin tags were groupable. I think when we get down to some of the OB services, some of them will be groupable, but I think we'll need to take them all one at a time, which will make this part slower just because it's a lot of code.
yeah.
So.
And maybe I can suggest that what you do is simply say which one you're on and ask for a motion, and the individual who suggested it or somebody who wants it can make the motion and explain to the group, and then you can ask for a vote. Maybe that's the quickest way to do it.
Okay, I am game for that.
Rather than discuss everyone individually, but if you would like to do that, those are kind of your 2 methods. You can either say, closed street radial head, is there a motion to approve? And if there isn't one, then you move on. If there is one, then you can discuss it, or you can just discuss it. So just trying to be helpful procedurally.
Yes, of like, how do we get through all these things? Because we're for sure doing this the next meeting too.
That's
so
right. It's important, so we don't have to go fast. I just want to make sure we're clear.
Okay, so maybe let's try that. Is there a motion to add the radial head subluxation? Okay. Is there a motion to add the removal of nose, foreign body? Is there a motion to remove or to add routine venipuncture?
Judy, this is Katina, I might move to add that because I think earlier when we were scrolling down, lab specimen handling was included. And I think I saw that was green. I was not driving at that point. I was in a parking lot, but I am driving now. So if that makes sense, to include that, I don't feel strongly about it, but just, I thought I saw lab specimen.
Yeah, I was going to motion for a routine venipuncture and capillary blood draw to add.
What do other people think? Okay, you can make that motion to add. We'll start with venipuncture. And those in favor of adding it, say aye.
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 And those against, say nay.
Nay.
And I don't know that we had that many people say aye or nay, but I guess we'll take that vote as it is. I'm hoping that I didn't make you all like too quiet by our overall conversation. Okay, so let's add venipuncture, and then I think there's a motion to add capillary blood draw, and so let's have the ayes.
Aye.
And any nays?
Nay.
And there are definitely fewer people that are voting on that one than even on the routine venipuncture. So I'm not exactly sure what to make of that, but we will add that for now. And then, yes. So insert temporary indwelling bladder catheter. Circumcision with a clamp or other device.
Motion to add for the circumcision with clamp and other device.
Agree.
Can we have some ayes?
Aye.
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 And any nays?
I'm a nay.
Nay.
Sorry to
Nay.
sound like a broken record.
Sounds like there's a few nays there. You know, one, yes. I don't know, Annalisa, if you have thoughts about that, or if we should come back to this at
I
the next
do. I think
meeting.
I think it's difficult because we can't, it's really hard in this format without electronic voting to determine
Yes,
who's
to
voting and
tell
what the
how many
majority is.
people.
So
Yes.
I think what we could do is say, if there are no nays, it's added. And that gives a lot of veto power to the nay, but it is also fairer just to say, if everyone agrees, we'll add it. If someone doesn't agree, we'll have to revisit, which means you'll definitely have to revisit, but at least you might get some of them clearly
Some of
added.
them
to the
knocked off.
election. Right, and you get a smaller field for the ones that are a little bit controversial. Does that
Okay.
seem reasonable to you?
I think that is a good way to
Okay.
do this because I am nervous. I think,
Right.
yeah, so routine venipuncture and blood draw, maybe we'll come back to both of
Yeah,
those. 'cause
so
I
I'm
think-
just gonna say
yeah.
on that one, I'm gonna put a little thing on here that says revisit. How about that?
Okay, because I am
And-
worried that there's not a lot of people voting for all of, yes, what is on there.
Right, so, and that doesn't mean you should definitely speak up if you don't want it added. It means all you're saying is, I want to discuss this later.
Talk about it more.
I know people can feel uncomfortable if they're the only voice saying nay, but all you're saying is, I want to talk about it more later. So please to do that. So now you're on, I changed those to revisit. And so if we have a if you don't get a motion, then it's out.
Yes.
If you get a motion and it's a unanimous yes, then we'll add it. If it's anything under the unanimous yes, we'll revisit. Sound okay?
I think that sounds perfect. Are
All right.
others good with that approach?
It works for me.
Yes.
Okay,
Makes a lot of sense.
Yes.
We're still
All
here.
right.
excellent. I know you're still with me. This is the hardest part of this for sure. It's a super long list. So bladder catheter, I think there wasn't a motion, is that right? So I think that's a no. And then circumcision, we'll revisit. So this next chunk, and I don't know if we should start in it or just set it up, but this next chunk is all care around delivery of babies, OB care, vaginal delivery, antepartum care, postpartum care, routine OB care, C-sections, postpartum care, all those sorts of things. And so I don't know if anyone wants to take a stab at whether, or maybe we'll just say, is there a motion on these? I suspect we might have to revisit this chunk, but.
This is
Crystal?
Katina. There's definitely a motion on these. I think, as I stated before, if it's happening in a primary care office by someone on our list that's primary care, this would be a huge chunk of care that would be left off if they're checking the other two buckets.
And I will remind you that we do have OBGYNs on our list of providers. And so all of these things would be included. It would not just be deliveries by family medicine folks.
So Judy, I'm seeing that Crystal has her
And
hand up.
Crystal has a question, yes, or
Yep,
maybe a comment.
I think it's just a quick question, but just confirming that these would be in the baseline of the OFM as far as the primary care cost of care.
They all are in the broad section. So one thing that the OFM section did is they made some things into a broad category.
Right.
You can see one thing that some states have done is decide that 60% of it is included, I think, to sort of get at that, like, is it OB care? Is it primary care? This is all a very blurry, sticky mess. And so states have taken different approaches, and we for sure can too.
Yeah, that's my only caution is knowing that cost, it could be pretty significant. So being clear about what the goal of getting more into primary care. Thank you.
Yes. And I think we're out of time. So
We
maybe,
are.
yes.
What if I put, we'll just make a note for Jean Marie that everything beginning with obstetrical care, you're gonna start there, and perhaps in the off she can develop a more efficient way. You know, it may be that we can do some electronic voting with the group with not being in a meeting. She and I will talk about that, but I do think you've run out of time.
Yes, we have run out of time. So thank you all very much for your participation. And we will see you next month, and we'll get back to you if there are some other ways we think of to try and make conversation about this list a little easier. Yes.
And just so you know, the recording and summary will be posted shortly on the website. And the next committee meeting is scheduled for Thursday, March 30th from 2 p.m. to 4 p.m. And this meeting is adjourned. Thank you so much.
Thank you.